We acknowledge and respect the Lekwungen, Songhees, Kapusim peoples on whose territory the university stands, and the Lekwungen Wasanich peoples whose historical relationships with the land continue to this day. And I know that many of us are joining from other places, and I'd like you to spend a moment thinking about the land which you are currently on and the relationship that you have with it and the people who also belong to that land. We are particularly blessed to be here at the University of Victoria, and it is something that we think about. You can see in many of our backgrounds for the folks here, parts of our campus. It's a beautiful place, and understanding our relationship to the land also helps us understand the relationship to the people as well. Okay, so I'm now going to turn it over to Dennis so that he can begin his talk. If you have questions, he's happy to entertain them. Feel free to raise your hands or to pop it in the question and answer box, and we will get your question to him. Thank you.
All right, thank you, Kevin. So thank you everybody for coming to today's presentation. The title of my topic is The Last Rewind, Ending ICD-9's Long Play in Primary Care in Canada. And the title, I got inspiration from this particular paper, Leaving the Walkman and ICD-9 Behind, Modernizing the Disease Classification System Used by Canadian Physicians. And the lead author of this paper is actually in our audience as well. So maybe we can have a discussion as well. And as part of this paper, the authors summarize that ICD-9 is no longer adequate for representing our modern healthcare environment and patient needs. And as part of this talk, that is what I'm going to try to describe as well. Here's an outline of my presentation, and maybe I should introduce myself, which I did not. So my name is Dennis Lee. I'm an assistant professor here at the School of Health Information Science. I've been here for about a year and a half. Before this, for the past 10 years prior, I was doing consultation work dealing with health terminologies and interoperability projects as well. So as today's presentation, I'm going to talk about ICD-9, ICD-9-CM in Canada, what's the status of it. Then I'm going to switch over to health terminologies in Canada, give you a broad overview, and then focus in a little bit more on SNOMED CT. The third part is talking about SNOMED CT support in Canadian EMRs. The fourth is looking at SNOMED CT related initiatives in Canada that can help us with the implementation of SNOMED CT. And finally, we will wrap up with some practical next steps that hopefully will try to get us over this hump of trying to implement SNOMED CT. So ICD-9 and ICD-9-CM in Canada, just a quick overview of it. So ICD refers to the International Classification of Diseases, and one is the ninth revision, and that was originally created by the World Health Organization for mortality and high epidemiology reporting. A few years after that, ICD-9-CM was created, and that's the clinical modification. So that was developed by the US. And what they wanted to do was expand it on just the basic mortality and high-level epidemiology reporting to include morbidity coding, reimbursement, and hospital utilization tracking. So ICD, if you're familiar with it, and I think most people should be familiar with it, it consists of numeric codes, and they are hierarchically organized as well. So there is limited granularity, but the codes are either 3 digits, 4 digits, or 5 digits. And basically, they're used to organize diagnosis and health conditions for statistical, administrative, and clinical purposes. So the first question, and we're going to try this today, is to launch a poll to see when do you think ICD-9 was first launched or first developed? Okay, so 16 people, I think almost everybody has voted. So somebody thought it was in the 50s, 60s, the majority, the 70s, some in the 80s, and some in the 90s. So the majority of you are correct. So this is a timeline of ICD, and ICD-9 was developed in 1975. ICD-9-CM was developed a few years later. So ICD-9 is essentially over 50 years old, and that's the terminology that we continue to use in Canada for primary care. So this is just a quick comparison between ICD-9 and ICD-9-CM. So once again, one is developed by the World Health Organization. The other one was developed by the United States. One was for the classification of mortality and morbidity, and then that was expanded in ICD-9-CM. ICD-9 was primarily in one volume, whereas ICD-9-CM was split into 3 separate volumes where you had the tabular and alphabetical index for diagnosis. And later on, they added the procedures, which included both the tabular and alphabetical index. I don't have an accurate count of ICD-9-CM because I couldn't find a machine processable list of just ICD-9 codes, but it seems to be roughly around 5,000 from some sources. And then for ICD 9 CM, the latest one that I found was that was the 2015 version that's slightly under 15,000 codes. But those are the codes that refer to the more specific ones. So some of the categories are not included in that count. So ICD 9, once again, released in 1975. And I don't believe there was any updates after it was released. Whereas for ICD 9 CM, it was used primarily in the US and in Canada as well. They had quite a few releases, and over the past decade or so, they did have yearly releases as well until 2015. That was the last time it was updated. So ICD 9 was replaced by ICD 10 in 1993, and ICD 9 CM was replaced by ICD 10 CM in 2014. So if you don't have any experience with ICD 9 or 9 CM, this is how it looks like. So this one over here on the left, this is showing you the tabular index. So if you click on any of these items, it will expand down to some of the blocks, categories, and codes. And also what you have over here on the right is the alphabetical index. So you can search for terms rather than looking at these categories or this hierarchy on the left. Now, what is important about ICD and most classification system is that there are a lot of guidelines that are included. So this is an example of the ICD 9 CM guidelines that are produced by the United States. This is about a 30-some page, and this is like the preamble. So within each of the tabular list, there are also guidelines within the codes as well. But this is sort of the preamble, so it's 30 plus pages. And one of the things I just highlighted in here out of this many pages was that they talk about using both the alphabetical index and the tabular list. So it says when you need to use both of them when you're locating and assigning a term, because if you only use the alphabetical index or the tabular list, this would lead to errors. So both of them talk about, or even the second one says, look at the alphabetical index, then take a look at the tabular list, make sure you read all the guidelines in there before you assign a code. And when you have codes that are 3 digits, 4 digits, 5 digits, if you have something that is more specific, you should use that as well. So these are just examples of some of the guidelines as part of the classification system. Now, when we call ICD a classification system, I need to back up a little bit and talk about, because there are many ways to refer to terminology. So terminologies as a broad term, it refers to a set of terms representing systems or concepts. So basically anything that we refer to, classification system, ICD, as normal CT, those can be broadly called terminologies because we're trying to refer to a system of concepts or terms. Now, control terminologies gets to be a little bit more narrow because we're trying to bound it to a specific domain or a specific area. But from there, you are split into reference terminologies, interface terminologies, and sometimes they call it administrative aggregate or reporting terminologies. So administrative aggregate and reporting terminologies, a synonym for it are classification systems where you try to group things together. Now, on the other end of classification systems are the reference terminologies. So these are terminologies where you have usually formal processing definitions at the back, and you can do all sorts of aggregation, all sorts of comparisons as well. Now, in between the reference terminologies and the classification systems are interface terminologies, and they're not mutually exclusive. That means a reference terminology can be used as an interface terminology. And an interface terminology simply means that you're using it on the screen, so people can use it to record information. Now, the first question will be, what's the difference between a reference terminology and a classification system? So I actually have students, guests in this class here or in this lecture who are my students as well, and we have gone through this where we try to differentiate between a reference terminology and a classification system. So I'll just give you some examples. A reference terminology that's for operational decision making. We try to use it for semantic interoperability, and I'll show you lots of examples later on when we talk about SNOMED CT initiatives. Whereas classification, you're trying to aggregate statistical data. You're trying to group things together with larger groups so that you can do more analysis. Reference terminologies tend to be polyhierarchical or multi-hierarchical. That means each concept within the terminology can have multiple parents, whereas classification systems tend to be mono-hierarchical. Reference terminologies, we tend to have a specific concept for each disease, each procedure, whereas classification systems, you do have what we call residual categories, and those refer to things like other, not elsewhere classified, not otherwise specified. So once again, reference terminologies, we try to assign a unique code or unique concept to each idea, whereas classification, sometimes we do group multiple things together. The last one is meaningful code systems. Usually when we have a reference terminology, the codes in there, they do not have any meaning, whereas classification systems do. Now, in terms of when should we use each of it, or before I get to that, the overlap between classifications and reference terminologies have faded a little bit. So nowadays, some of the newer classification systems also have characteristics of reference terminologies as well. So if you look at this diagram over here, things like ICHI, CPT, ICD-11, and ICNP, which is now SNOMED CT, they do have characteristics of both reference terminologies as well as classification systems. Now, as to when should we use each of this, there are some guidelines over here. So this is a paper by Bramley who talk about a framework for evaluating classification systems, and this was the distinction that you was trying to make. So, for example, in reference terminologies, that's what we're trying to use, data collection at the point of care. It is more of an input system that we want people to use. Whereas for a classification system, it tends to be an output system. So you do not use it as a point of care. You usually do it after the fact, where you review the entire patient record and assign a code to it. So reference terminologies, that's where we're trying to capture really detailed information. So diagnostic studies, history and physicals, exam notes, problems, procedures. And being able to capture at this granular level will allow us to be able to send and receive medical data. Hopefully, it will also allow us to improve the quality of care because we have this granular information. And with that, we can run all sorts of decision supports as well, such as reminders and alerts. We can do also patient case queries. We can also link to the literature. Whereas for classification systems, they have primarily been used to be able to focus on costs and outcomes. They are basic health statistics. It's used for payment systems, especially in Canada. When you submit a billing code or the intervention or procedure you're doing, you usually have to submit 1 to 3 different classification codes as well. If we take a look at the landscape of Canada on the different versions of ICD, so we use a combination of ICD-9 and ICD-9-CM, and I think sometimes provinces, when they report what they're using, they're even unsure of what they're using. So Alberta is using ICD-9-CM. It is publicly available. If you recall, we had the 2 volumes. They do not have an alphabetical index, but they do have the tabular list that has chapters, blocks, codes. They do have some guidelines, not as the preceding or the preamble, but within the tabular list. And if you take a look at all the purposes here, they're mainly for claims assessment, claims processing, for billing medical services as well. If we look at all the different versions as well, there's a combination of ICD-9-CM and ICD-9. I put a star for BC because BC, we do say we're using ICD-9, but there are actually some ICD-9-CM codes as well. So not everybody has it publicly available. I've tried to reach out to some provinces and they say, nope, you can't have it. It's only for vendors. So as part of some of the analysis that you see afterward, it's only based on what is publicly available. Most of the time, or in fact, all of the time, nobody produces it or publishes it with the alphabetical index. Sometimes they have codes and blocks. Sometimes they just have a list of codes or chapters and codes as well. But as you can see here, most of them do not produce the guidelines, which is one of the key things in using ICD-9. So as you recall, we said you do have to look at the alphabetical index and the tabular list to be able to produce an accurate code as well. But this is a summary of how it looks like in Canada. For the provinces that have published their ICD codes, this is how it looks like. So in Yukon, there's 18,000 codes in there, whereas for Newfoundland and Ontario, it's a much smaller sample. Ontario, especially, they have made quite a bit of changes. So in my previous slide, I said it was ICD 9-ish because they made quite a bit of modifications to the terms in there. But as you can see, even though in Canada, we are supposed to be using ICD 9 or 9-CM, across all the provinces, it is very different on what content is available, and also in terms of when it was last updated as well. And some of this last updated dates does not necessarily mean it's the version of ICD-9. Sometimes some provinces also add additional codes as well. So across the spectrum of Canada, we are using many different versions, many different number of codes. If we take a look at comparisons between each of the provinces, you can see there is a wide variety of where the ICD-9-CM code overlaps. This is just an example of how it is with diabetes. So for example, in Alberta Health Services, which uses ICD-9-CM, you can see the granularity in which ICD-9 has for diabetes, whereas for BC in ICD-9, not 9-CM, we have fewer codes, except these two are supposed to be ICD-9-CM codes, but somehow they are in BC's codes. In Ontario, diabetes over here, they call diabetes as a section, but when they refer to diabetes itself, it's just 250. So they basically have one code for all types of diabetes in here. So you can see the spectrum and the different levels of granularity across the provinces. Now, if we take a look at essential hypertension, we can start to see that Alberta and BC have quite similar descriptions. BC, we just like to put everything in caps. Manitoba and Yukon also, they seem to be quite similar. And Newfoundland and Labrador and Ontario, they also have a similar way of organizing it. For Quebec, I can't read French, but it's quite similar to Manitoba, I think, as well, or BC. Some of the first four provinces, they have a similar set of codes in there. Now, one of the things to note is that these are the examples of the distribution file. So each of these provinces, when they distribute it, they do have content available that you can download. So this is how it is in Alberta. And if you have subsequent pages, you'll be able to see the tabular list. One thing to note over here on why they use it, for example, it is a little bit small on the screen, but over here in BC, they talk about they want the MSP data to be able to verify claims and generate statistics about the causes of illnesses and death. In Ontario, they talk about serving as a universal language in the healthcare industry. They talk about accurate billing, transparent communication, efficient processing, data analysis, and legal compliance. There are some challenges with it. Now, this report is really dated. It's from 1996. It's the only one I could find. I did contact the Ministry of Health, but this was the only document that they said they had. But it says some of the coding is not really accurate and reliable, especially when you get to the fifth digit in there. So that's one of the challenges of using it. Physicians are not trained in using ICD 9cm. They do not have the necessary documentation, and sometimes the coding that they submit is not really accurate. This is another example of being outdated and lacks the content coverage. So what I was trying to look for when they talk about trying to verify claims, the services are provided as well as having a diagnostic code. So I tried to search for it. And Dr. Care over here, a Wellstar company, had actually a list. These are, for example, for mental health. These are the codes that you use for billing, and these are the diagnoses that you should use in conjunction with it. An example that stood out to me was gender dysphoria over here, and it said use ICD 9 over here, so 302. And when you take a look at this code, we can't have a discussion here, but when you look at the set of these codes here, I think you will be unimpressed with the content coverage and the outdatedness or the language that is used in here. So ICD 9, once again, we're using a classification system that is many years old and has not been updated. Now, in terms of looking at all other countries that have been implementing various versions of ICD, you will see that starting in the 1970s, at the end of 1970s, that's when all the countries started to implement ICD-9. But you can see toward the early 1990s when ICD-10 came out, everybody started to switch over to ICD-10. So basically in Canada, we are one of the few countries that use ICD-9 extensively. I think the US might be the only other country, but that's some of the legacy systems that they have. Most countries have shifted over from ICD. So those are some of the challenges, and here's a summary of it. So physicians not trained to use ICD-9 and 9cm. Physicians should not be using a classification system at the point of care because we did a comparison between reference terminologies, classification systems. They are not designed to be used at the point of care. While ICD-9 and 9cm is used primarily for billing, as we saw those requirements for the provinces, it is widely used for diagnosis and problem lists. It's outdated, it lacks specificity, it has insufficient coverage, and provinces use a lot of variations of ICD-9 and 9cm, which decreases comparability. So that sets the stage. I know that was really fast because I know I have plenty of slides and I need to get through everything. But are there any questions? If not, I will continue going. Everybody's fine?
None so far.
Okay, so next we're going to take a look at the health terminologies across Canada. So this is a timeline of the development of health terminologies that are used in Canada. It's just a draft, but this gives you an overview of what other terminologies are available in Canada. And I use terminologies as the wide, broad word that includes both reference terminologies as well as classification systems. So it actually, there's some others that go earlier than the 1970s, but we just start from the 1970s because that's when ICD-9 and ICD-9cm came about. And then in the 80s, we had the ATC, the Anatomical Therapeutic Chemical Classification System, as well as the Canadian Classification of Diagnostic, Therapeutic, and Surgical Procedures. Now, CCP is not really used in Canada as is, but a lot of our coding systems, especially in Alberta and Nova Scotia, they were based on the CCP. So there's some legacy components of CCP that are still in there. In the 90s, we had the ICD-10 version. We had a drug product database. I think it was about 1994. I don't seem to have a definitive date. Loin came out during then, ICNP as well as Medra. And then in the 1990s, that's where we had our own version of ICD-10. We had the Canadian enhancement and we had the Canadian classification of health interventions that was supposed to replace CCP. Now, one thing to note in that in the 2000s, exactly at 2006, Canada Health Info Way, they had a committee or a group, and what they said was that SNOMED CT was the best choice of terminology for 24 priority clinical information groupings, and that included problem-less diagnosis as well. So this is back in 2006. And their recommendation was that SNOMED CT captures clinical information at a level of detail needed by clinicians for the provision of care in all healthcare disciplines and most healthcare settings. Now, just to finish the rest of this timeline before we get into more details on SNOMED CT, in the 2010s, we also had PCLOT, that was the Canadian extension of LOINC. We had the Licensed Natural Health Product Database. We finally had our Canadian edition of SNOMED CT. The 11th revision of ICD came out as well. We also had the clinical drug data set. And in the 2020s, I think we're going to have the Canadian medicines terminology. I think it's going to be released probably this year as well. They're still currently working on it. So this gives you a broad spectrum of all the terminologies, and there are many different organizations that we work with to be able to use the terminologies, work with them to be able to maintain and enhance the terminologies as well. So the purpose of this diagram is just to give you an overview that terminologies includes many different organizations. There are national terminologies, international, there are vendor standards as well. And to categorize it and to make it a little bit more viewable, we have drug and product terminologies. We have those that are related specifically for diagnosis, those for labs, procedures, and we have also other categories as well. So this makes it a little bit more easy to manage all the different terminologies that we saw across the previous two slides. Now, we're going to talk a little bit about SNOMED CT, and the question for you in the second poll is, which of the following are correct? Okay, so, wow, that is a lot of answers from a lot of places. That was unexpected that we will have almost all the answers. Oh, nobody wants SNOMED over here with a W, but somebody wanted the SNOMED with a W over here as well. So as you can see, there's a lot of different misconceptions on what SNOMED CT actually is and how it should be referred to as well. The answer, actually, there's only two of them that are correct, the ones that I have bolded in here. So it's SNOMED CT without a dash, and it's SNOMED clinical terms. All of the others are not supposed to be used, and they're not advised by SNOMED International. Okay, I'm about 30 minutes in. I think I should be okay. So I do have a slide that talks about some of this referencing SNOMED CT correctly, but that's a good way to take a look and see how people think SNOMED CT should refer to. But for those of you who are not familiar with SNOMED CT, I'm just going to talk a bit about some of the core building blocks. As part of the certification program that we teach, we go into many weeks talking about SNOMED CT as well. But the building blocks of SNOMED CT and most terminologies are concepts, and concepts are abstract clinical ideas. Because they are abstract clinical ideas, what we want to do are to be able to add descriptions to it. A second component of it is we want to be able to structure the concepts in a hierarchy, because oftentimes you may have 10,000s, hundreds of thousands of concepts, and it's not feasible to have them as just one long list. And because we talked about reference terminologies, each of them has a formal definition in the end. We also do have attribute relationships in there. So for example, we have a clinical idea such as myocardial infarction. We may add additional descriptions such as MI with an abbreviation, myocardial infarct, cardiac infarction, heart attack. And then when we're trying to arrange this concept into a hierarchy, we can try to identify what the parent concepts are. For example, we can say it is one of the parents is ischemic heart disease and another is myocardial necrosis. And when we try to define what myocardial infarction actually means, we can say it refers to something related to your myocardium structure, and it refers to a morphologic abnormality of infarct. Now, this is how it looks like in the SNOMED CT hierarchy. So once you have those parent concepts, you are able to structure a hierarchy like that. So you do have the broad concepts at the top of the hierarchy, and you go into the specializations and have the more detailed concepts lower down in the hierarchy. So from there, you're able to do a lot of aggregation as well, comparison. That's what we like to do with classification systems, be able to group things. So even with a reference terminology, we can pick certain sections of the hierarchy to be able to do aggregation. And this is just how the diagramming guidelines of SNOMED CT looks like and how we represent this particular concept. So that's your quick overview of it. But if you want to know more about it, actually, I should have swapped the pages. I have a book that I will recommend you in a couple of slides. So here are some quick facts about SNOMED CT. It's the most comprehensive clinical reference terminology. It has almost 380,000 concepts, over 1.4 million descriptions, 1.3 million relationships. It supports concise, precise, and machine processable representation of clinical information. It's supposed to be used in over 80 countries. How exactly they are used, we don't exactly know, but we know that they are used in over 80 countries, translated in at least 12 different languages. It's maintained by the International Health Terminology Standards Development Organization, or IHTSTO. And this organization was founded in 2007, and Canada is one of the charter members of it. Right now, the organization includes 52 member countries and territories, and this is just an overview of all the different countries, territories that are using SNOMED CT in one form or another. So if you want to know more about SNOMED CT, there is a book that was written by one of our colleagues, Dr. Linda Bird. So she also teaches as part of the certification program, so you can get this book as well. You can get it as an ebook online. So there's a lot of content that goes through all the details. So it is the essential guide to SNOMED CT. So one of the things we want to do is that, okay, we know that ICD 9 and 9CM is used extensively across Canada. We know that SNOMED CT is one of the best choices to replace ICD 9, especially for clinical documentation. So what is the SNOMED CT support in Canadian EMRs? So as part of a study I'm doing, I went across and tried to find all the different certification programs, all the different lists across Canada in which they mention what EMRs are used. So this is what I found in there. So there are 30 different EMR vendors that have been listed by provinces on what should be used within there. For Saskatchewan, I put it in this yellowish color because I couldn't find an exact reference document that said these are the three in there, but it seems that other documents reference that says, yes, we are being used in Saskatchewan. So 30 different EMR vendors in there. These are some of the examples on how they reference that they use SNOMED CT or how they support SNOMED CT. So for Accuro, in this whole user guide, as you can see, many different headings, subsections in there. SNOMED was only used one time in the wording in there. So it says ICD-10 and SNOMED indicator search. The indicator search in the add prescription window searches on ICD-10 and SNOMED. And that SNOMED is not the wrong way that we'll refer to SNOMED. So that's how it is in Accuro, the one way that they mentioned the support for it. In Plexia as well, I could only find one reference to it. So it says fix an issue with switching an existing problem search by from ICD-9 to SNOMED CT. At least SNOMED CT is used correctly in the reference here. In ARIA, it says that a new medical history entry field will appear with a smart search drop box of SNOMED diagnosis that you can select from. So I took a look at this website. I think it was last year when I went back to this website just to check. I couldn't find this exact screenshot anymore. So I'm not sure whether they still actually support it because it was no longer there. One of the best places to find who supports what is the Ontario MD website, because each of the certified vendors, they will have a section that talks about the coding standards, and it will describe what are the coding standards in there. So this says SNOMED, which is not actually the right way that we should refer to SNOMED. So these are some of the vendors and how they reference their support for SNOMED CT. So as part of this research that I'm doing, I'm trying to find out which EMR vendors support it. I've tried to contact vendors. Some of them would talk to me. Most of them would not. They probably are afraid when we give them the consent form, that there's this big consent form and invitation to participate and all that. But I did talk to a few vendors. A lot of times they did not know that SNOMED CT even existed. So some of the questions we wanted to ask was, does the EMR support the Canadian version of SNOMED CT if you do support SNOMED CT? Does the EMR support the use of subsets? Does it support the use of maps? And how about data retrieval, some of that subsumption and the aggregation in there? So out of this 30, there were only, I think it was 7 of them that supported it in some vague language in there that says, yes, we do support SNOMED CT in some form. A lot of them do not support SNOMED CT. I went through all the documentation, their guides for people who talk to me, and a lot of these EMR vendors do not support SNOMED CT in any shape or form, which is unfortunate. So what we are going to get to is the This maturity level, yes. So I was on the Snowman International website, and there was this maturity models that they have for various aspects. So they had some for a country level, they had some for like an organization level, they had some for the maturity level for software products. So this maturity level, there are 6 different levels, including level 0. And what we can see based on what we saw from some of the documentation from the EMR vendors is that a lot of them were at level 0 because no implementation of SNOMED CT in clinical or administrative systems. Or some of them that had SNOMED CT, it was used in isolated areas with minimal integration. So that is the landscape of where we are at in SNOMED CT and the support in EMRs. Now, even though we do not have much support in primary care, in EMR vendors, there are a lot of SNOMED CT related initiatives in Canada. And I use the word initiatives quite broadly to say that anything that relates to SNOMED CT, I'm just going to highlight some of it here, not all of it, so you just have an idea of what is available. So most important, we do have our own Canadian edition. It's freely available. Everybody can download it from Canada Health Info. We can also browse it on the SNOMED International SNOMED CT browser. There is the CMT as well, the Canadian Medicines Terminology. So we do have the drug product database. We do have the Canadian Clinical Drug Dataset, but now we're going to have our drugs represented in the CMT and SNOMED CT as well. In the past, we have a lot of our immunizations in there, but we are expanding it to more drugs as well. So right now, they have completed phase number 2 from what I could see from the latest update on March the 2nd. And after that, they're going to continue with the rest of the drugs in there. There's also, everybody I think is familiar with this from CIHI's, the Canadian Core Data for Interoperability, or I'm not sure how you pronounce it, the CACD version 2. So these are all the different sections within this interoperability report and all the areas in which they recommend SNOMED CT subsets to be used. So for example, the major ones are like the health concerns, the procedures in there, those are the bulk of it. And even for medications, we're starting to use more SNOMED CT as well. So it is a little bit more encouraging that even though primary care, I keep saying primary care, EMR vendors do not support SNOMED CT, there are different organizations and initiatives that are pushing toward it. Now, this is how it looks like once you get into the details of that report or that document. So it talks about the health concerns over here. And when they talk about the terminology foundation, in this case, they say use 3 different hierarchies in there. Use the events, the situation with explicit context, and use the clinical findings. And then if there's no problem at all, you can use a single situation concept as well. They understand that we do use ICD 10 CA and ICD 9 as well. So there are alternatives in there. But in this case, there are over, I think it was about 20 different areas that they support or recommend SNOMED CT as the terminology foundation. Going back to Canada Health Info, so where you download SNOMED CT, you get it from the terminology dashboard or the Onto command. There's also the shrimp browser as well as the snapper to do authoring and browsing as well. And all these are freely available for us in Canada. There's also the patient summaries project. So there is the international patient summary that I think most of you are familiar with, the IPS, and multiple provinces are working on their own version of the patient summary. And we also have the pan-Canadian patient summary. A lot of the elements, terminology binding also relates to SNOMED CT. And that's how the CIHI is also aligning with the patient summaries. The National Vaccine Catalog as well, everything within there has been transitioned over to SNOMED CT. So they do have all the trade names in there. They also have vaccine preventable diseases. I think there are 6 or 7 different subsets that are related to SNOMED CT in the vaccine catalog. And also, for example, I know other provinces also have it, but because we're in BC, we have the BC Ministry of Health, and I just got this latest file actually yesterday because they updated it to version 2.2. So they do have the BC health concerns and diagnosis value sets. So one of the questions is, how do we enhance some of the data that we have with SNOMED CT? So one of the ways is that we try to represent whatever we have in the past to SNOMED CT so we can do mapping. And in this document or in this spreadsheet over here, there's actually a mapping to ICD-10 as well as ICD-9. So if you take a look at the historical data on what you have with ICD-9, you have a migration pathway to say what is it equivalent in ICD-10, in SNOMED CT. And with SNOMED CT, because of the hierarchy, we can try to enhance that multiple ways. One is we can look at some of the subtypes of the hierarchy as well. So ICD-9, because it's a high level, some of them are grouper concepts. With SNOMED CT, we can find the equivalent, and then we can drill down the hierarchy to see what are more detailed concepts. Another thing that we can do is to look at other subsets that have been developed by other countries, and I have that as part of some of the practical steps as well, to see what other people are using as part of the concepts for different subsets. So these are just some of the initiatives in Canada that gives me a little bit more hope that SNOMED CT is moving along. When I came to do my master's at UVic, that was 20 years ago. I didn't have any background in terminologies. I didn't know what kind of project to do. So my professor said, go with terminologies, go with standards. That is something that will always be around, and that's something that we need. So as part of my master's project, I did it with a colleague, and we did mapping between ICD-10 and SNOMED CT. So at the time, SNOMED was just coming out. The first official version was 2002, and I think I started in about 2005, 2006. So SNOMED CT, we don't even need to talk about ICD-9. We're going to be talking about ICD-10, how SNOMED CT relates to that. And that was, once again, that was in 2006, about 2006. I did my PhD in about 2014, and the project focused directly on SNOMED CT, trying to demonstrate the value of SNOMED CT. How do we use it? How do we audit it? How do we do data retrieval? And yet, 10 years later, after my PhD, I'm back here talking about ICD-9. So for my master's, doing ICD-10 to SNOMED CT, and then now we have to go back and talk about ICD-9 to see how we can end the last rewind of ICD-9 and move on to a reference terminology. So what are some of the practical next steps that we can take to move toward that direction? I'm going to finish in a few minutes so that we can have a discussion. So there is the Digital Health Interoperability Task Force, and they made multiple recommendations in there. Those are broad recommendations, such as providing guidelines to the provinces, securing commitment, some of it through legislation, how we can erase barriers. These are excellent recommendations, and if you have not read this report, I do recommend that you read it. It has lots of details. They understand what are the issues at stake, and they provide steps. Some of the steps are a little bit broader, like legislation that would take a bit longer to complete. So as part of this presentation, I'm just going to give you a few practical steps that hopefully we can take over the next few years that we can move us in the right direction. So one of the first things is that we should refer to our terminology correctly. So back when I was doing I think it was doing my PhD. I was part of the SNOMED implementation advisor team. So since SNOMED CT was still fairly new, they had this program where they would take people who are interested in implementation and provide us with training on how the terminology should be implemented. So this was back in 2014, and I can remember the very first day in class. This was the slide that we had, putting in a good word for SNOMED CT. It's SNOMED clinical terms or SNOMED CT with the R. Do not use SNOMED with the W. Do not use the dash. Do not use it this way. Do not even use systematized nomenclature of medicine except as a historical note. This was back in 2014. And unfortunately, as also when you saw from the poll, there's a lot of misconceptions about what is the best way to refer to SNOMED CT, because it's in the literature, it's on websites, all these different ways. Even through this presentation, I highlighted different areas. You would have seen a lot of different people in their papers, in their website, refer to the wrong way of SNOMED CT. Even if you go to CIHI's website right now and Canada Health Info's website, they do refer to it as the systematized nomenclature of medicine in both of their websites, even though ideally, that's not the way we should refer to it, except as a historical note. I think I showed this to some of my classes, or I will show it to you when we talk about technical requirements over here. So this is a little bit dated. This is from Ontario MD back from 2015, but you can see how they refer to SNOMED over here with a W. Even if you take a look at the literature, so this is an article from JMIR. They say that SNOMED CT is a systematized nomenclature of medicine clinical terminology. It's the clinical term. So one of the first things that we need to do, I think, is to put a good word for on what SNOMED CT is. Now, what we need to do is also to start to engage broadly with stakeholders and provide education for that. As part of SNOMED International, once again, they do have this maturity level for members. So these are member countries. So they talk about 6 similar levels as well. And this is where I highlighted a couple of the places where I think we are. So once again, we are about since we were a charter member, that's almost 20 years of being a charter member of SNOMED International. So we have no tracking or adoption of alignment with health strategies. We have no, I said, minimal use of SNOMED CD for clinical data analytics or healthcare environment. I think we have very basic engagement because when I talk to physicians, I talk to the vendors, they're like, no, we don't know what is SNOMED CD. What are you talking about? This terminology that you want us to implement of it. And it goes both ways. They will say, okay, we will only implement these features if the physicians ask for it. But the physicians don't know about it either. So it seems we're in a catch-22 that nobody knows about it, so it won't be asked for, it won't be implemented. Now, the part that we are a little bit more advanced is the national edition. So we do have, as I showed you, we do have our national Canadian edition. It's released every 3 months. Everybody has access to it. Now, whether we can get that into our EMRs is another question. In terms of spreading the word, we've tried before. For example, there's a few physicians that we tried to write a commentary to CMAJ. We said, you know what, maybe that's a great way. It's not a research paper. We'll just write a commentary about, I think it was 500,000 words. And in the end, they rejected it. If you take a look at their website, so this was a search for SNOMED to see how often SNOMED is mentioned in there. So one of it was by Ray Simkes. I'm sure a lot of you know Dr. Simkes, and it was just him talking about SNOMED CT, but it was not about implementation of SNOMED CT. And two of it were just cursory mentions of SNOMED CT as well. So one of the things we need to do is broad engagement with medical associations, whether it's provincial medical associations, physicians, and especially the vendors, because we cannot do this without the vendors, and most vendors are unaware about SNOMED CT. Now, the next one that I think is a practical step is to develop pan-Canadian EMR technical specifications. For those of you who are here that are in my class, we are actually going to talk about it on Tuesday on drawing up technical specifications. So if you take a look at some of the papers, they say one of the challenges in specifying interoperability requirements is the difficulty to specify concrete requirements to describe the needs properly. And this was referenced in multiple papers as well, and was one of the main key areas. Well, the good thing for us is that this has also been recognized by the Digital Health Interoperability Task Force. This is failure of EMRs to support interoperability. And what I put in here in red, that's me, that's not them, is due to the failure to define requirements as well. Because what happens is across Canada, if you have to have your EMR certified, there are different set of requirements in all the provinces and territories, which make it very difficult for EMR vendors. So what we need is to have pan-Canadian standards technical requirements. So implementing SNOMED CT, there are many different ways that we can implement SNOMED CT. We can use it as a data entry engine. We can use it for data retrieval. We can use it to structure our clinical record. So many different ways to use it, and we can provide more detailed requirements on how that can be done. And we already have multiple requirements from different provinces, from different countries as well. So for example, Canada Health and Way, this was an excellent guidelines that they have, the user interface guidelines that says how should you develop your screens, what are some of the best practices. In BC, we also have the EMR user guide that tells us how to use the BC health concerns and diagnosis value sets. SNOMED International also has their requirements, but we don't actually have a set of technical requirements for EMR vendors in Canada. And these requirements should provide a pathway on how you would implement SNOMED CD. And one of the starting points could be, you know what? ICD in the past is just a code and a description. We can start from that point. We don't have to import the release format to requirements, or because those are, I think there's 20 over files. By the time you import it, it's 3 to 4 gigabytes in there. There are many different steps that we can take to help EMR vendors implement SNOMED CT. Now, the next one is also to develop primary care subsets, and I briefly alluded to that earlier. So SNOMED CT, if you look at the clinical findings, if we're just talking about diagnosis and problems, there's over 130,000 different concepts, and that's way too many for what we need as part for primary care. So one of the things, once again, going back to the Digital Health Interoperability Task Force, they say there is a lack of broadly mandated data nomenclature and exchange standards. I added the thing in there, subsets as well, because I think subsets is one of the ways that we can make it easier to implement something that is more practical to implement SNOMED CT. Now, the good thing is that there are many subsets that have been developed both in Canada as well as worldwide. So in Canada, we do have all our vaccine sets, we have some data entry sets, we have some subsets referred to top-level hierarchies, and that's primarily used for terminology binding for some of the fire profiles. And Australia, Belgium, Ireland, and India have lots of subsets that have been created as well. And you can access most of these subsets through the SNOMED CT international browser as well to see what fits. Now, they're not necessarily subset that fits directly to primary care in Canada. So there's a few things that we can do. For example, because we're using ICD-9, we do have the BC doctors, they have produced this ICD-9 family medicine diagnostic code. So these are the most commonly used codes for primary care physicians or family medicine. So it's not the thousands and thousands of codes, but it's 255. From here, we can map it to SNOMED CT and identify what are the concepts related. So some of the potential subsets, we can do the mapping to that. We also have the BC health concerns subset that I referred to earlier, and I think I might have it on one of the next, or I think I showed it to you earlier as well. Canada Health Infoway has the health concerns code reference set. That's quite large. That's almost 40,000. There is a common one that is 4,000. In the US, there's also the National Library of Medicine that has one that has 6,000 as well. So there are many different code sets that we can pick from, but we can also look historically what we have used in the past and try to create a set that is very specific for primary care physicians that is manageable for implementation as well. Now, the last step that I have listed in here was to integrate SNOMED CT into AI Scribe. So there's been a lot of talk about the use of AI and how it affects us in healthcare. And Canada Health Infoway in the past year or so, they have provided 10,000 fully funded 1-year AI Scribe licenses. Unfortunately, when I went to look at all these different websites that describe the tooling that they have, none of them include terminologies as one of the features. So having AI Scribe already takes you quite a ways away because everything has now been summarized and has already been written in a narrative form rather than audio. But the next step would be to use NLP coding to be able to represent those terms with SNOMED CT. So those are 5 things I think that is practical that can be done. A lot of the things that have been described by the task force are also much larger as well, such as legislation. Everything is important as well, but there are multiple ways that we can try to tackle this issue of trying to finally get rid of ICD-9 over 50 years and try to move over to SNOMED CT. Okay, and I think I managed to reach the end of my presentation. Unlike my class, which I sometimes go over time, I have managed to finish on time so that we can have some questions and a discussion.